Our next speaker, Callie Chamberlain, has a bright light that shines from within. She has been a champion for health equity throughout her career, and today she will walk us through the intersection of maternal health and health equity. So please welcome Callie Chamberlain.
But they don't give you any choice 'cause they think that it's treason.
Hi, everyone. I'm thrilled to be with you this afternoon. Even if only virtually, I'm really looking forward to our time together. My name is Callie Chamberlain, and I'm the Director of Social Responsibility at Optum. Optum is one half of United Health Group. We are the products, the services, and the technology. The other side of United Health Group is the organization United Healthcare, which some of you may be more familiar with. That's the insurance provider. And before I tell you a little bit more about what I do and our maternal health strategy at Optum, I'm going to tell you a little bit about who I am and how I come to this work. I'm a woman, I'm a person of color, I'm of Asian descent. I'm based in Minneapolis, and I have spent so much of my summer thinking about systems change and racism across America, in large part due to the murder of George Floyd that happened right here in my hometown. And as we go through this, you might actually hear sirens or helicopters as we prepare for the trial of Derek Chauvin, so fair warning. Professionally, I've been fortunate to have a number of experiences that have profoundly shaped my path and continue to guide me in terms of the values that I use every day at work. I started my career in health and then I left for a few years. One of the things that I did during that time was I launched a leadership and development program called New Leaders Council Twin Cities. That organization is committed to advancing equity across the region and bringing together young people who are leading from a similar set of values so that in 5, 10, 15 years, as we become more visible, we can pick up the phone and call on each other to get things done. That organization is 5 years old and has more than 70 local alumni. Another thing that I did is I went to the Greek island of Lesbos with 6 other women to film a documentary on the Syrian refugee crisis in Greece. That film debuted in Times Square in 2019. It went on to win 7 awards. And most importantly, it told the stories of women refugees and entrepreneurs. And because of the relationships that we developed on the ground and a consistent ask that we heard for people that just wanted dignity through work, we created a microwork application that connects refugees to income opportunities on their cell phones to leverage the 6 hours that they spend every day waiting in line. And as a result of that, I had the privilege to work across the Middle East and North Africa with the United Nations as a peacebuilding fellow to develop more comprehensive migration policies. That time away also included running a donut shop and a political t-shirt shop. So it was a lot of fun and I learned a lot. And despite those experiences, or I guess maybe because of them, right, I made my way back to healthcare. Around this time, the social determinants of health were just coming into focus, which had much more expansive definitions of health and healthcare, ones that I really felt like I could see myself within. And because of my work with refugees, I really started to realize that health is the base of equity. And without it, we don't have anything. You can have the best education in the world. You can have a safe place to live. You can have a fridge full of food. You can have a job with a paycheck that you know is coming every 2 weeks. And none of that matters if you don't have your health. So as healthcare professionals, I think the work that we do is really unique because we have the opportunity to positively impact the health and the well-being of thousands of people, of millions of people, or not. The decisions that we have the privilege to make, they really matter. And I don't mean to be dramatic about that, but oftentimes it really is life or death. And almost always about quality of life while people are still alive. And to me, there's nothing more sacred or profound than having the opportunity to do something about that. And in a capitalistic society with a for-profit healthcare system, I think the opportunity to be able to do real social good is most prevalent in the private sector. And that's why I'm at Optum. But this work is also deeply personal to me. I am one of the 1 in 5 people who have experienced discrimination in the health system as a result of my race or ethnicity. I have seen up close the ways that this system wasn't built for me or people like me. And I mean, I know we say that all the time, right? The health system is broken, it doesn't work for everybody. But what we don't always say is that that's intentional. A system functions exactly as it was designed to function. And this system, this health system, was built and created in 1798. And at that time, women were not seen as full human beings, much less women of color. So when I say that this system wasn't built for us, I mean that. That's fact. And with the COVID-19 pandemic and the increasing violence in our communities, the social uprisings that were happening globally and right outside my front door is ground zero, it really became clear how many public crises we are operating within and how many systems are functioning exactly as they were designed to function. We just can't ignore it anymore. We just can't look away anymore, right? We can't ignore all the statistics that we're seeing, all the inequities that have been laid bare. That's something else I hear all the time, right? Yeah, we can't ignore that that's happening. We can't ignore that race is at the foundation. We have to do something about it. And I don't know about you, but I feel that, right? It's not just systems change and racism across America out there. It's right here in our work, in the health system, in the medical industry, right across our laptops, right? That's the opportunity. And that means that we have an unbelievable moment to meet. And I think that we can lean into it and understand our ability to impact social issues at scale. And I think the way that we're doing that at Optum is really unique. We're reflecting on who we are and how we arrive at this work, at this moment. And I think that what we're doing can provide a really unique framework that I hope is helpful to you and your organizations. And that's what I want to share with you today. So to give you some background, my colleague and I started the social responsibility program at Optum 3 years ago. We both come from very entrepreneurial, non-traditional backgrounds. So we run a very entrepreneurial, non-traditional social responsibility program, which is to say that we're not a philanthropic grant-making body. We are the second largest health system in the world. So we believe that the most impactful, responsible thing that we can do is change the way that we do business, right? So that means changing our processes, our operations, our culture. And in doing so, we really believe that we can shift the industry and change the field. So about a year ago, we decided to focus on health equity. And then about 8 months ago, we decided to zoom in on maternal health. We did an incredible amount of research. There are so many things we could have selected, right? We read over 1,000 studies, we talked to experts, we surveyed our staff, and we considered where we might be best positioned to authentically move the needle. And around that time, I was completing my birth doula training. So, all right, what's a birth doula? If we were in person, I would literally make you be like, what's a birth doula? So just pretend you're doing that, and I'm gonna pretend that I can hear you. And oh my gosh, I'm so happy you asked. All right, so a birth doula is somebody who supports a birthing person throughout pregnancy, delivery, and postpartum. A doula helps a birthing person have the experience that they wanna have and prepare for an addition to their family. They help someone advocate for themselves and navigate the health system, which are two things that have never really sat right with me. So let's go back. The first thing that I said is that a doula helps someone advocate for themselves. And what this is inherently acknowledging, right, is that oftentimes women are not heard. They're not believed in care settings, and they suffer as a result of that. So the doula is there to help amplify their voice. The second thing that I said is that the doula helps somebody navigate the health system. So we've already landed on this system was not created for us, and that has real ramifications today, and the doula is there to help navigate that. In academic and historical terms, I believe the correct term for a doula is a village auntie, which is to say somebody who has been through the experience of birth and rearing children and is able to support the birthing person throughout that process. In spiritual terms, a doula is someone who bears witness to someone throughout the experience of birth. A doula is someone who recognizes birth not just as a medical event, but as a spiritual one. They are someone who facilitates a conversation between the birthing person and God, Allah, Buddha, the Great, whatever your inclination. They hold the space while a child moves from the spiritual realm into the physical one. Now, I see my work in deeply spiritual terms. And I take the tenets of doulaship with me into everything that I do, especially my work at Optum. And I think it's a really beautiful metaphor to think about how we can transition and change, because we're always cycling through something, right? That's a natural process of life. Beginning and end, life and death. We're constantly birthing something, creating something, whether that's a new idea or something that we can physically see, right? We do it at work, we do it in our families, we do it in our communities. We're doing it across society right now. We're birthing a new world and we're laboring for that. So I see my role in social responsibility in a similar way to that I see my work as a doula. My role is to clear out all the barriers that prevent the spiritual experience from occurring. That means addressing everything from implicit bias to paperwork, administration, all the business side of things, right? And on the patient side, it's about preparation, education, translating materials. I'm clearing out a way for anything that prevents a patient and a provider from both showing up, fully present in their complexity and humanity, to be in deep relationship to one another. That is the kind of experience that I believe every person deserves to have every single time that they interact with the medical system, and especially when they're having a child. What I'm talking about is seeing people as patients in care settings instead of consumers in a marketplace. And this idea is at the very core of our maternal health strategy at Optum. That's our opportunity, that's the invitation, to work at the intersection of race and gender and change how maternal health looks across this country. And let me give you that landscape, right? Because it's important context and it's kind of horrifying. So in the United States, we have the highest maternal morbidity and mortality rate of any developed nation. I want you to know that most of those deaths are considered preventable. Think about that. Most of those deaths are considered preventable. We have an undersupply of maternal care providers, and we're the only country to not guarantee access to provider home visits or paid parental leave, two things that we know bolster maternal health. So in total, what this means is that we spend the most on our healthcare, we have the least amount of services and supports, and therefore we have the worst maternal health outcomes. Now, two other things. I don't think we realize that most people are one paycheck away from being on Medicaid. So that means that we need a broader definition of who we're caring for and how that happens. The second thing is something that a provider said to me. They said, Callie, sometimes I have a patient that's pregnant, they have their baby, right? And then maybe I don't see them until they get pregnant again because life is happening and they can't get a ride to my office, or their coverage changes, or they're working a lot of jobs. Oftentimes it's all of those things. And then if there's any risk, any complication, the rate of morbidity is already so high that by the time I see them again, I'm already working backwards. This really helped me put the work of maternal health into a broader social context. We can't talk about reduction in maternal mortality and morbidity without talking about women's health. We can't talk about reduction without addressing the social determinants of health, without talking about access and care supports. And with these things in mind, we got to work. We put our most vulnerable birthing populations in the center because I believe that when we solve for our most vulnerable populations, we actually solve for everybody. And for us, that means Black, Indigenous women of color. That means women who are incarcerated, birthing people who are experiencing domestic violence. That means people who can't easily access care, and people whose experiences never make it into any of the research that informs clinical practice. That's who we centered. And we selected grassroots organizations that were on the ground, that were doing the work, and we said, we want to allocate dollars to you, which we don't normally do, like I said, but we said, look, we want to partner with you. We love what you're doing. We can amplify this work together. Let's go. We launched pro bono projects to build organizational capacity within our grant partners, which help them stretch their dollars. It had the secondary benefit for us of being able to engage our staff and helping them understand more about the maternal health space. That also helped them interact with and understand patient populations that maybe they didn't understand before, they don't look like, they haven't had a chance to interact with, right? And as a third benefit, that actually started to change our organizational culture. People started to think more expansively about who we were providing care for, how we thought about creating our products and services, all of that, right? We matched our partners with internal sponsors who could further identify opportunities for our work to support one another. And then because our social responsibility program is focused on internal systems change, we work with our partners to see how their strategies and insights can inform our strategies, and then how we can continue to advance their work on the ground. It's a virtuous cycle, works really well. One of our partners, Ladies of Hope Ministry, is launching a doula training program for incarcerated people. Participants will learn to become doulas, and then once they're released, they'll be able to obtain support to launch their doula businesses. They'll also have the opportunity to join a speakers bureau where they'll help pass legislation to prevent shackling. I don't know how many of you know this, but today in 23 states, it's common practice and totally legal to physically restrain someone who is incarcerated and having their child to a bed, shackle them to a bed. And from a doula perspective, when you are having sexual intercourse and when you are physically laboring and having a child, your body's actually running in parallels, biologically, physiologically. So what that means is that if you have experienced any level of sexual trauma and now you are being physically restrained, you are likely being re-traumatized. How deeply dehumanizing. That is the furthest thing from a spiritual experience. So we're starting to work on that. One of our partners, the Morehouse School of Medicine Center for Maternal Health Equity, is conducting research on near misses to ensure that the lived experiences of women of color become a data point in future research. It's the first of its kind. We're working with the Wake Forest Baptist Health System and the Family Justice Center in Winston-Salem to intervene at the time of a domestic violence 911 call. If there's a pregnant person there, we'll make sure that they've got all the supports that they need, that they have a medical pathway, that they're getting their prenatal care. We're expanding access to care by developing financial sustainability models with a federally qualified health center, which is where most people who are uninsured or underinsured are receiving care. And like I said, people are moving between the population of being insured or uninsured all the time. We're hoping that we can take that more broadly across the country. We're developing a remote patient monitoring program with our clinics in Washington State to ensure that birthing people understand how to advocate for themselves and monitor for their own symptoms. Another is scaling the work of Cradle Cincinnati. In Ohio, Hamilton County, they had the nation's second highest infant mortality rate. And then they started creating spaces for Black women, what they call Queen's Village. And they were able to reduce that rate by 24% in 5 years. That's pretty incredible. And as their executive director says, to make better decisions on infant mortality, we followed Black women. So all of this in total, I think is great. I'm obviously biased, right? But it's really not about us. It's not about how we show up as a Fortune 5 company. It's not just about how we do good. It's about how we fundamentally shift maternal health across the health system and bring it closer to equity. It's about how we show up as co-conspirators in the work and reestablish trust with communities of color. It's how we heal this part of the medical industry's past and begin again together. I think of two things almost every day. The first is a quote by Martin Luther King Jr. He said, "Of all the forms of injustice, inequality in the health system is the most shocking and inhumane." And the second is something that I saw written on a sidewalk, and it said, "You're more powerful than you think." It was in a little kid's handwriting. So I want to pass those messages on to you. And I want to encourage you to think about the second quote to consider how you address the first. You are more powerful than you think that you are. And inequality in the health system is the most shocking and inhumane. It is the most shocking and inhumane. And if I may, I'm going to ask you to deploy your social, financial, institutional capital to join me in building a just and equitable health system that actually works for everyone. I'm going to encourage you to draw a circle around your most vulnerable populations and to design the systems with them that they need. And that's a distinction, right? You're not designing for them, you're designing with them. And in doing that, what I'm also inviting you to do is to be awed by what people are forced to carry instead of judgmental of how they carry it. All of that in service of building authentic relationships with our communities, which we're a part of, right? Individually, as a group, as an institution, as a medical industry, we're a part of these communities. And to show up with the sole intention of listening, learning, and being in deep service and relationship. Let's model what we want to see happening within the four walls of a care setting in our organizational partnerships. And ask yourself the questions that I opened with. Who are you? How do you show up to this work? And then ask yourself those questions from an organizational perspective. We need every single person here thinking about how we orient toward health equity. It will literally require all of us. That's what I'm birthing. I'm willing to labor for it every single day. and I hope that you'll join me. Thank you.
Thank you so much, Callie, for your brilliant opening keynote and for inspiring us with your work, your passion, and your mission.